Hello. We're privileged today to be able to have a discussion with Professor Paul Ridker from Harvard Medical School. As we all know, Dr. Ridker has made numerous seminal contributions to cardiovascular medicine and bring forward this whole issue of inflammation being a very, very important component of the mosaic of factor increasing risk of cardiovascular disease. So, Paul, thank you very much for joining us today.
It's a real pleasure to be here.
Now, what brought you to medicine, actually, if I may ask first?
It's actually a very personal story in some ways. My father was in the Foreign Service. My father's a professor of economics, and we lived in India for several years. And when I came back to the United States, I ended up being a patient as a very young kid at the National Institute of Health in Bethesda, Maryland, to figure out why, when we lived in India, I had picked up some certain parasites. And it's a wonderful story, really, about how some people get introduced to medicine, because the physicians who took care of me at the National Institute of Health, they were clinician scientists. And I was naive enough to think later on in my life that all physicians worked in this wonderful milieu where they had a laboratory, they took care of patients, and I said to myself, that's what I want to do. A bit funny to think about the fact that many years later, that's not what all of us do. But for any young people who are happy to be watching today, it's a wonderful career. And I was very lucky to have my introduction to medicine being through that route.
So then, what about cardiology? You know, any major influence who this got you interested?
So I was a student at the Harvard Medical School and finished around the time when the AIDS crisis was just beginning. Very interesting how certain things have very big impact on how you think. And I had actually spent a year in Zimbabwe doing medical care, thinking I was going to be an infectious disease physician. My interests had been in immunology and innate immunity, thinking that infectious disease was where I'd end up. But I was lucky enough to do my internship at the Brigham Women's Hospital in Boston, where I met Professor Jean Brownwald, who very politely told me I was going to become a cardiologist. And the one thing I've learned is do not disagree with Dr. Brownwald on anything. And I took that advice, and here we are today. But I think my fundamental interest in innate immunity, immunology, applying that to cardiovascular medicine has actually been the key to this whole field.
And you start publishing right in the mid-'80s, right? 85, I think, was your first paper?
Well, I did have some publications at a very early time that were sort of transitional projects between medical school and residency. But a second very lucky thing happened. I often talk about how serendipity is important in life. I think you have to be open to the experiences that happen to us. I met a very eminent epidemiologist, Charles Hennekins. Now, Charlie Hennekins at the time was running this big study called the Physician's Health Study, which of course would go on to show that aspirin was very effective at lowering the risk of heart disease and primary prevention. And I had met Dr. Hennekins when I was a medical student, and I knew that he had been putting away blood samples as part of the Physician's Health Study. Well, fast forward 10, 12 years, when we began to think about how might we go about the process of asking, does a alteration of inflammation or innate immunity predict heart disease? I remember that he had these blood samples banked for very different purposes as part of his Physician's Health Study, and that gave us the window of opportunity to begin this whole process.
And I guess this is the story behind this now very famous New England Journal of Medicine paper in 1997, where you first provide the evidence in this trial, right, that this marker of inflammation may be, we need to pay attention to CRP, right?
Well, one of the wonderful opportunities was that Dr. Hennekins' Physician's Health Study had this attached biobank, and we had a wonderful scientific collaboration with Russell Tracy at the University of Vermont, where they had been trying to figure out ways of measuring CRP with this new higher sensitivity assay. Plus, we had a lot of, again, serendipity in that the Physician's Health Study was a randomized trial of aspirin, a drug that was an antiplatelet drug, but also had anti-inflammatory effects. And so what that original paper from 1997 was able to show in one set of experiments was, first, if you measure inflammation with this broad biomarker, which we now call hsCRP, we could predict heart attack and stroke. The stroke data very important because we knew cholesterol didn't predict stroke. Secondly, we could show that it was chronic, long-term. Inflammation was a driver of this process over many, many years of follow-up. And third, the randomization to aspirin was crucial because the people who got the aspirin, while they benefited overall, a much larger risk reduction if you had inflammation than if you did not. And I think we were lucky enough to make the insight, perhaps that's a signal that if we modify inflammation, we might have an opportunity to attack atherosclerosis in a new way. So that one 1997 paper really would lay out for us the next 20 years of work.
Must have been received with huge controversy at the time, right?
Yeah, it's easy to look back and say, well, this paper became very influential, but you're right. The grant that we wrote to support that paper was never funded. The reviewers had a very difficult time, but I'm very grateful to the reviewers of the New England Journal. In fact, Attilio Masri, one of the pioneers thinking about inflammation in Italy, wrote a magnificent editorial for that manuscript. And the title of Professor Masri's editorial was something like Looking at the Dark Side of the Moon. And the idea had been, here we have an epidemiologic tool to ask a fundamental vascular biology question. We could see that dark side of the moon for the first time. And I've always been very fond of Attilio for having written a very positive editorial, which I'm sure is why the paper was published.
So Paul, after this initial landmark New England paper came a plethora of systematic studies where you have really secured the notion that C-reactive protein was an independent marker of risk, right?
Well, we had a very structured set of studies that we were interested in performing. The first study, the Physician's Health Study, was in men. So the next logical step was, let's not simply try to reproduce this, because replication, of course, is very important in any scientific endeavor, but let's replicate it and extend it. So the second study was in women. That was our women's health study data. But we said it's not simply CRP. We also measured then other markers of inflammation, IL-6, ICAM-1, serum amyloid A, and that paper said all these inflammatory markers predict risk. So the next insight was it's probably not CRP per se, good clinical biomarker, inexpensive, easy to use, but the process of inflammation matters. And then we began to ask questions, could we reduce inflammation? Are there any drug studies available to us? That led us to work with Mark Pfeffer and Frank Sachs, who had run the CARE trial, secondary prevention. And we're able to, again, go to an existing biobank and say, well, it looked like the magnitude of benefit of being on a statin was greater in secondary prevention among people who had inflammation and those who did not. Very important insight into how these drugs might work. And in fact, that was the original data we published in 1997, 1998, saying that statins lowered CRP and that the magnitude of inflammation inhibition, if you like, was not related to the LDL reduction. That would then lead to working with the AFCAPS TexCaps investigators, who had shown that lovastatin was very effective in these low HDL metabolic-ish patients.
Would you say that this last study was really the one who was, I would say, was the basis for the Jupiter trial?
Absolutely. We had a very strong idea of what we thought Jupiter would become. Jupiter begins as an R01 to the NIH, but we had no pilot data. And pilot data becomes crucial once the studies become expensive. And so AFCAPS TexCaps was a pilot saying, when patients with low LDL and low CRP were given a statin, there was simply no benefit, no clinical benefit, even though the LDL came down. But when the LDL was low and the CRP was high, now we saw enormous clinical benefit. But AFCAPS TexCaps, even though it was published in New England Journal of Medicine, that paper, it's a post hoc analysis of an already completed trial done for other reasons, and we've all learned we must do prospective studies to solve this. So we took that piece of information. If I randomized the low cholesterol, high CRP patient who would never receive a statin under any guidelines, would they benefit? Already knowing that the low CRP patients would not. So that leads to Jupiter. And from there we now have this wonderful set of data helping us to treat our patients.
Yeah, we'll come back to Jupiter because, as you said, this was a study, a trial specifically designed to address a very specific question regarding targeting and inflammation with a statin. But also at the same time, you were very much involved in modeling issues in terms of risk prediction, and that has been another very important contribution from your group, how to integrate CRP in global risk assessment. In your lecture earlier here at the Quebec Heart and Lung Institute this morning, you raised the issue of the problem of assessing global CVD risk in women. For instance, with the Framingham algorithm, could you comment on that and what you've come up with to sort of improve risk prediction, for instance, in women?
Sure. So one of the advantages of having formal training in epidemiology and statistics, as well as formal training in biology and native immunity, was our ability to cross many fields and speak the language of different kinds of investigators. So in this particular realm, I had the opportunity to work with a tremendously talented biostatistician, Nancy Cook, who's one of my closest colleagues now in Boston. And from a purely biostatistical perspective, we said, look, how do we develop a modeling system to define risk beyond Framingham using this new biology? And we measured a wide array of biomarkers in almost 30,000 women. We measured Lp(a) and ApoB and homocysteine and CRP. We did a genome-wide scan, and we also had a question about family history. And all this data went into a very sophisticated mathematical system that Nancy designed. And what came out is what's now called the Reynolds risk score. This was funded by the Reynolds Foundation from a very important cardiovascular support foundation in the United States. And the Reynolds risk score incorporates the Framingham covariates, blood pressure, HDL, total cholesterol, but adds in family history of heart disease as a surrogate for genetics, and it adds in a CRP. It's a very risky process for me because it might not have worked. Again, one of the real messages in science is being your own best critic and designing studies that may or may not prove your own hypothesis. But the CRP did make it through this. And quite gratifying to see in the Canadian guidelines, for example, and in the new US guidelines, the Reynolds risk score is now considered a very viable alternative to Framingham. It's particularly important, as you point out, for women. As I think most listeners are probably aware, very few women have a Framingham score above 10, much less above 20. And what we knew is that these women had very high risk, particularly for stroke. Women have a higher risk of stroke than do men. And that Framingham had systematically underestimated that risk. And one of the dichotomies in this field is that there are many examples of people who have rather low Framingham scores and rather high Reynolds scores. That doesn't mean Reynolds is better yet. You still have to show that there's an intervention you would give. So an issue that's very important for me is this question. It's not enough to show that any test, an imaging test, a biomarker, CRP, even HDL, predicts risk. The fundamental question becomes, is there an intervention I would give my patient that he or she otherwise would not have received? Because if I'm going to give them all diet, exercise, and smoking cessation, or I'm going to give them a statin anyway, measuring this might not help my clinical algorithm. So that second question, I think, is the piece that's often been missed.
And incidentally, for those of you interested, the iPad application that you can download for free on our website, www.myhealthyways.org, includes actually the Reynolds risk score. So we have more than 20 different tools to assess, for instance, quality of the diet. The Framingham, obviously, algorithm is included, but you'll have the opportunity to realize that in some circumstances, especially in women, there could be quite a bit of discrepancy in estimated risk, whether you use a score that includes CRP and family history in women compared to the Framingham. Now this brings us to this landmark Jupiter trial. Personally, I must confess that I liked a lot the Lancet paper, which provide additional information compared to the initial New England 2008 paper.
Well, there's actually, I'm pleased to hear that because I like that paper better too, to be honest with you. We purposely had two separate pre-specified sets of analyses. What came out in the New England Journal was the fundamental result of the trial. If I take people who would never get a statin because their absolute risk is considered very low, but they are selected because they have a high CRP, that paper made it very clear. 44% reduction in the trial primary endpoint of all vascular events, 55% reduction in myocardial infarction, 50% reductions in stroke, bypass, angioplasty, 20% reduction in mortality. The New England Journal paper was the fundamental findings of the trial. But the Lancet paper that you're referring to was also the pre-specified manuscripts. It was almost written simultaneously. That paper said, what was the fundamental driver? Was it LDL reduction alone? Was it CRP reduction alone? Or was it some combination of these two? And of course, what that paper really concluded was, yes, we had a 50% reduction in LDL, and that was a great benefit for our patients. Very consistent with the Canadian guidelines, suggesting a 50% reduction is a good target. I completely agree. We also had a roughly 40% reduction in CRP. And it was very clear that the patients who were randomized into Jupiter, who were lucky enough to respond to the drug with not only a large LDL reduction, but also a large CRP reduction, they had almost an 80% reduction in events.
Indeed.
And what we've learned is you cannot predict, at least clinically, you can't predict which patients are going to get a large LDL reduction, which are going to get a large CRP reduction. That insight was very similar to what we saw in our earlier studies of acute coronary ischemia, the Prove-It-To-Me 22 data. It's also very similar to what they saw in the reversal trial, that when CRP came down and LDL came down, benefits were larger. So I think that's the beginning of the insight saying, look, all statin trials the last 20 years have had this dual physiology. All statins lower CRP, they all lower LDL. How convinced are we it's only the LDL component, or should we be open to the hypothesis that perhaps lowering inflammation per se might matter? And that's been a really exciting question.
And obviously you are conducting trials to address this, confirm this inflammation, targeting inflammation hypothesis. Now going back to risk assessment, obviously you have improved, you've come up with an improved tools. How do you see the future of risk assessment? Obviously now some colleagues around the world are suggesting that we should include imaging. Personally, I'm not really in favor of that. I think that we probably can figure out pretty cheap markers to identify the quote-unquote vulnerable patient. What's your take on that?
Fascinating issue. There are really two very divergent schools of thought. One is very high-tech. Everybody should get a calcium scanner. Everybody should get a CT angiogram. I am not in that camp at all. I am very worried about that approach because, yes, it predicts risk, but it also only detects very advanced disease. And the one thing we have all learned is that it's the early non-calcified lesions that are actually our problem. So the only reason calcium predicts is because it's a surrogate for other non-calcified lesions I can't see. But if the patient has no calcium, why am I so reassured they don't have the kind of plaques I'm worried about? Plus there's radiation and a lot of expense. At the other extreme are individuals who are saying, look, I think we can just look at blood pressure and maybe measure waist circumference and maybe get also a very good handle on this. And the reason I have sympathy for that worldview is because risk prediction itself in primary prevention, the rationale for doing so has radically changed. We used to do it 20 years ago because we weren't sure who should get advice on diet, exercise, and smoking cessation. We now recognize everybody needs that advice. So there's no reason to risk stratify for that anymore. And for therapy, for pharmaceutical intervention, it's basically statins. And we now have clinical trials that say, well, west of Scotland, if your LDL is high, you should be on a statin in primary prevention. AFCAPS, TEXCAPS, if HDL is low, you benefit from a statin. Jupiter, if your CRP is high, you benefit from a statin. So now the question becomes, why do I need anything beyond those three simple biomarkers? Because I have no evidence that the low LDL, high HDL, low CRP patient benefits from a statin. So even if I identify high risk in that group, I don't know the drugs are going to work. So you have to do that trial. And I've argued publicly that if you really think imaging is the way to go, I don't need imaging for the people who are already being treated. You can only image the people who don't currently qualify for a statin, and then you need to randomize them to a statin to make sure that the drug actually is effective in that group. And I don't see that happening anytime soon. So my sense is some very simple biomarker panels, a general physical exam is probably going to be the solution, at least until another class of drugs that comes along that we don't have certainty about efficacy. But that's a way off.
Now, you're also wearing your public health hat, because you had expertise, quite a bit of expertise in that field as well. Now, the dilemma, when we look at more, I would say, quote unquote, toxic world, we have the average BMI in Canada and the US, we're not really different from you south of the border. It's in ballpark of 27, 28, I would say 70-75% of the Canadian adult and the American population is either overweight or obese, and now massive obesity is now something quite prevalent in the US. Of course, those patients, because they have a metabolic quote-unquote disease, would definitely benefit from statin therapy, lowering blood pressure. Now, from the public health angle, where do you think we need to go?
Well, first, I completely agree. The Canadian and American body physique has become remarkably similar, which is a tragedy for both countries.
Correct.
And I think some of this is education. Some of it is where we decide to put our public health dollars and our prevention dollars. I give a lot of credit to Michelle Obama, who is really trying very hard in the United States to have a public health campaign based on improving quality of food intake. Glycemic load issues are being discussed. Issues that are very akin to your own research about how do we not only understand the biology of this metabolic abnormality, but how do we now put it in place, and how do we promote a not just heart healthy, but I would argue metabolic healthy lifestyle in a setting where our current fiscal policies are to support the wrong kinds of food industry. In the United States, we still subsidize beef, and we don't subsidize the growth of fresh vegetables. So it's no surprise that the most vulnerable people in our society with the least income to provide expensive food are eating the worst food. And we have to change that. But there are some wonderful examples that it can be done. In Massachusetts, where I have the pleasure of living, we have a trans fat shift. All restaurants now fry in different kinds of fat. And that's brought down lipid levels, it's brought down CRP levels. We're in the midst of a salt reduction campaign in the United States to try to get across the board slightly lower levels of salt over the period of several years. That should bring down the average blood pressure in the United States. But these are large policy initiatives that require tremendous political insight, and I would argue great political skill to bring forward. But we must do something about this. And it's not just Canada and the United States. If you look at Mexico, if you look at India, different populations that have an even worse epidemic of obesity and metabolic syndrome even than we do, it's very clear now that developing societies are going to rapidly shift from very low atherosclerosis rates to very high rates of diabetes and atherosclerosis in a matter of 20 or 30 years. And so one of the reasons I so much appreciate what you're trying to do in your research as well as in these webcasts is the educational issues about obesity, diabetes, insulin resistance, its interrelationships to heart disease. These are the crucial public health issues for the next 30 or 40 years, and they're going to be particularly crucial in those societies that are rapidly advancing. And we have to ask questions about how can we take the knowledge that the first world has, hopefully protect our colleagues from going through that transition so rapidly. It's going to be very difficult.
Mm-hmm. And you and I also believe, because we do that for our own health, we believe in regular, vigorous exercise, and I think it's very important. Sometimes practicing physicians are sort of think that they cannot do anything for their patients because they don't have the tools and the resources to help their patient change their lifestyle, but at least to really raise the awareness in a couple of minutes with the patient, address the issue that physical activity is probably the best poly pill there is out there, and obviously notwithstanding the fact that the statin will save clinical events, will save life. These are remarkable cardiovascular drugs, but we really, health professionals, really have the responsibility to really emphasize that, bring the level of noise higher around physical activity.
Well, I can't agree with you more, and I think that like in many things in life, one leads by example. So I know that in the dead of winter here in Quebec that you will be out running every day
Correct.
in your winter suit. I know that you've ridden your bicycle in some very bad inclement weather, and it's important that your patients know you're doing that. I remember many years ago when we were trying to tell our cardiac surgeons, you can't smoke cigarettes. How can you be a cardiac surgeon smoking cigarettes? It makes no sense. It's the wrong model for our patients. I think the same thing applies here. We as physicians have to make it very clear that we believe this, and we are spending 45 minutes to an hour of our days in our very busy, complex lives exercising. There's a reason our patients should do it too. So I congratulate you on all that running.
And this is, I'm glad you're raising this issue because it comes up all the time. I don't have time to exercise. I guess we're both pretty busy professional lives, but it has to be a priority in the schedule, right? Otherwise, obviously, there could be one more meeting to run.
So, like you, I suspect we have similar practice. I see a lot of executive type men and women who have very complex lives like ours, and they say to me they don't have the time. And I make the argument, look, I know you have a fancy job in a fancy building downtown Boston, but get rid of that executive parking spot. I don't want you parking in the nearest spot to the elevator. I want you to park about a mile away and walk in and walk back. You can be on the cell phone, you'll get work done, but at least you've now built in 2 miles of walking each day. If your office is on the 25th floor, get off the elevator at 20 and walk the last 5. So you're building in exercise during the day. And I must say that if you just do those kinds of things, even if you don't have time to run or play tennis or do what you really enjoy, at least you have restructured our environment. You have to recognize that the physical environment most of us live in is very hostile to our health.
Indeed.
And elevators and escalators are not the way to a healthy heart. And so I think there's ways of building this in. All of my patients, particularly businessmen who fly a lot, they are instructed to put sneakers and shorts in their bag. They go to the gym at the hotel they're at, and I really talk to them a lot about how that's how I do it. I have the pleasure of working with Peter Libby, as you're aware, and Peter, as many people know, is always running mini marathons and things, and it's the same thing. It's leading by example and actually showing that the exercise matters. In fact, Charlie Hennekins, the way my career started, Dr. Hennekins and I met because I had played collegiate squash and tennis. Dr. Hennekins, when he was younger, was a world-class squash player. And all through Harvard Medical School, I had this very famous professor I was playing tennis and squash with. I still play with Charlie many, many years later. And again, he led by this example of being a scientist and an athlete, and his care and interest in health, I think, was part of that presentation.
Now, you have had a fantastic career in academic medicine. I would say now we're both the same age, in the early 50s. If you have now to reflect on your career and give some advice to trainees, residents, fellow clinicians at the beginning of their career, it's a little bit it's a difficult environment those days for academic medicine. Which would be your advice? Is it still fun? Of course, it's more difficult, but what type of advice would you give?
Well, first, I think, first and foremost, I would say there's nothing I would prefer to do, period. I really enjoy what I do. I have the opportunity to spend some of my time in very direct patient care, some of my time very direct teaching of students at the medical school level, at the residency level, at the fellowship level. I have a certain amount of my time fundamentally doing basic biology, and some of my time doing these very large population studies. It's all incredibly interesting. It's very exciting. It gives a very diverse sense of pleasure and interaction. And I have colleagues all over the world like you who I get to have wonderful relationships with. I can't imagine a more fun career, and I can't imagine why everybody doesn't do it. It doesn't mean it's easy, but no career is easy. And I'm convinced no less now than 25 years ago, if you're committed to a research career, a translational research career in particular, it's very doable. Certainly it's difficult, but both of us have lived through times when NIH funding was very difficult before too. This is not the first time there's been a funding problem. People make it through. There's ways of doing this. I really believe that the biology that we're all seeing is so exciting. The next 20, 30 years of cardiovascular medicine is going to be extraordinary. And why wouldn't you want to be part of that? So I'm very optimistic, and I think we have tremendously talented young people who come and work with us. They have wonderful ideas. Our job as senior investigators is to make sure they have a way of getting through that path. So I guess what I'm partly saying is be optimistic, but find a good mentor. They really do matter.
Well, on that note, Paul, I want to thank you very much for your generous contribution today. Thank you.
It's an absolute pleasure.